Welcome back, everyone. If you're prepping for your medical board exams, you know that infectious diseases can just be a massive web of complex facts to memorize. But today, we're bringing you a highly focused, high-yield explainer specifically on trypanosomes. We're going to completely strip away the fluff and give you exactly what you need to master both American and African trypanosomiasis. We've got a visual breakdown that's going to help you build a solid mental model, one that's going to stick with you all the way to test day. So let's just jump right in.
So think about this for a second. Can a completely painless bug bite lead to heart failure literally decades later? I mean, it sounds like some kind of medical mystery movie, right? But this is the very real clinical reality of these pathogens. We aren't just talking about a simple fever or a rash here. We are dealing with silent, delayed destruction. These parasites are absolute masters of stealth. They can hide out in the human body and manifest in fatal ways long after the initial exposure. And honestly, this is exactly why examiners absolutely love to test you on them.
Okay, let's dive right into this. Here's our roadmap so we can compartmentalize all these facts. First, we'll look at a tale of two parasites, then Chagas disease, followed by sleeping sickness, and finally, we'll hit those high-yield exam traps.
All right, starting off with part one, a tale of two parasites. We're looking at the American versus African variants.
So here is the baseline mental model you really need to establish right now. We have American trypanosomiasis, which is caused by Trypanosoma cruzi and not relies on the triatomine bug, also known as the kissing bug. Then, contrasting that, we have African trypanosomiasis. That one is caused by Trypanosoma brucei and carried by the Tetsis fly. You really need to keep this geographic and vector distinction rock solid in your mind, because getting these two crossed is just a guaranteed lost point on the boards, and we definitely don't want that.
Moving right along to part two, let's focus on Chagas disease and Trypanosoma cruzi.
Now, what is actually super interesting here is the precise mechanism of infection. The triatomine bug bites its nocturnal host, right? But it doesn't inject the parasite through its saliva like a mosquito does. Actually, no. It defecates during its blood meal. I know, gross. But it's the bug's feces containing those metacyclic trypomastigotes that get rubbed into the bite wound, the mucosa, or the conjunctiva. This is a massive exam buzzword, guys. You absolutely must remember. It is the feces, not the saliva. So let's say a patient presents in the acute phase with this specific entry route. What classic sign are you looking for? Boom, it's Romana's sign. This is defined as unilateral, painless periorbital edema, right at the conjunctival entry site. So if a test question mentions a patient from Latin America waking up with a swollen, painless eye, you immediately, and I mean immediately, think of the acute phase of Chagas. But, what happens when that acute phase ends? Well, in the chronic determinate phase, the real systemic damage occurs, and it can take decades. The parasite causes dilated cardiomyopathy and a really classic left ventricular apical aneurysm. But whatever you do, don't ignore the digestive tract. These patients can develop an achalasia-like megaesophagus and a Hirschsprung-like megacolon. And why does that happen? Because the parasite literally destroys the intramural autonomic ganglion cells. This is high-yield pathophysiology right here, folks. So the crucial point here is how this cardiac damage actually manifests on an electrocardiogram. If an examiner wants to test your knowledge of Chagas cardiomyopathy, they are almost certainly going to hand you an ECG reading. You're looking for a right bundle branch block combined with a left anterior fascicular block, RBBP plus LAFB. Do yourself a favor and commit that exact combination to memory. Okay, so how do we fight this? Your first-line treatments are benznidazole or nifurtimox, and honestly, they are highly effective in the acute phase. But you've got to look closely at the contraindications and constraints. You absolutely cannot give these during pregnancy or to a patient with advanced renal or hepatic failure. And here's the real kicker. These drugs have zero impact on the progression of chronic cardiomyopathy, and they definitely won't fix those severe digestive complications we just talked about. Once those ganglion cells are gone, well, the drugs just can't bring them back.
All right, let's pivot across the Atlantic for part three, sleeping sickness, also known as African trypanosomiasis.
It is absolutely necessary to separate the two variants of the African pathogen. This brilliantly illustrates why the details matter. First, we have TB gambiense, found in West and Central Africa. It's anthroponotic, meaning humans are the main reservoir, and it causes a very slow chronic progression. Then, contrasting that, we have TB rhodesiense, found in East Africa. This one is zoonotic. It lives in antelopes and cattle, and it is violently acute.
If an East African game park ranger or, say, a tourist on a short-term safari gets sick rapidly, you are definitely thinking rhodesiense.
Let's take a look at the key signs. Just like Romana's sign for Chagas, sleeping sickness has its own pathognomonic marker, and that's Winterbottom sign. This is the enlargement of the posterior cervical lymph nodes. And listen carefully, you must associate this exclusively with the slow-moving Gambian-C variant. Rhodesian, on the other hand, presents as a rapid, acute febrile illness, with a really high fever, diffuse myalgia, and myocarditis. In stage 2 for both variants, when the parasite actually invades the central nervous system, that's when you see those classic sleep disturbances. Sleeping all day, wide awake all night, along with severe psychiatric symptoms and personality changes.
1,000. So why is the number 1,000 significant here? Well, this represents the approximate number of variant surface glycoprotein, or VSG genes, that the African trypanosome possesses. It uses these genes to constantly switch up its surface antigens, effectively outrunning the host's immune response. It's like a master of disguise. And this incredible immune evasion tactic is exactly what causes that cyclic parasitemia you see in the patient's blood.
Treatment for sleeping sickness is incredibly specific, and it's frankly fraught with some severe constraints. Fexinatidol is the preferred oral treatment for Gambian-C. For stage 1 rhodesians, you're going to use Suramin, but you have to monitor very closely for nephrotoxicity. Now pay attention to these next 2 points because they are crucial. If a patient is in stage 2 of rhodiency, they require melarsopril. But be warned, this is a highly toxic arsenical compound. It actually causes reactive encephalopathy in up to 18% of patients, which can literally be fatal. Finally, eflornithine is an excellent drug for Gambian-C, but it is completely contraindicated for rhodiency because, well, it just isn't effective against it at all.
Okay, time to bring it all together. Section 4, high-yield exam traps. Let's make sure you don't fall for these classic multiple-choice pitfalls. When the board examiners inevitably ask you about diagnostic testing, I want you to visualize this exact breakdown. For TB Gambienses, the primary serologic screening tool is the CAT, or card agglutination test. For the rapid rhodienses, there is actually no serologic screening available. You rely directly on the blood smear. And for chronic Chagas disease, T. cruzi, you need not 1 but 2 positive serologic tests, and they have to use entirely different antigens to actually confirm the diagnosis.
All right, let's rapidly debunk some of the major distractors they love to throw at you. If the exam trap says infection is via bug saliva, remember the reality. It's the bug's feces. If an option pairs Gambienses with East Africa, cross it out right away. It's West and Central Africa. If they try to tell you Chagas evades the immune system via VSG variation, do not fall for it. That mechanism strictly belongs to African sleeping sickness. And finally, eflornithine is not some magic cure-all. It is only effective for Gambienses. Before we wrap this up, I want to drop one last high-yield cross-disciplinary pearl for you. You know how infectious disease often links up with immunology on the boards, right? Well, in immunocompromised patients, specifically those with HIV and a CD4 count under 100, Chagas can actually reactivate. And when it does, it becomes an AIDS-defining illness that presents with CNS toxoplasma-like lesions. You really want to keep that firmly in your differential diagnosis toolkit. Wow, we have covered a tremendous amount of ground today, so I'm leaving you with this final thought. Basically a classic mockboard setup. A patient presents with a right bundle branch block and a history of South American travel. What bug feces cause this? Think about the vector, think about the pathophysiology we discussed. Locking down active recall questions exactly like this is what bridges the gap between just studying and true deep understanding. Keep running through this explainer until these visual patterns are just second nature to you. You've got this. Good luck with your exam prep, and we'll see you next time.